So when I was young, I had a friend, and his mother, every now and then, she was away from home for a while. And when she was away from home, his father took care of him together with a neighbor who helped. And no questions were asked, so we all took that for granted. That was just something that happened every now and then. And then after some time, she always came back home, and again, no questions were asked. It was as if nothing had ever happened, and everything went back to normal. And it was only very later on in his life that this friend learned that his mother, during those times, had manic episodes with psychotic features. And that in the periods when she was away from home, she was admitted to hospital. And he also learned that she didn't talk about that not only with him, but also not with his father. And he also learned that these experiences have been very traumatic for her, and not because she resisted treatment and that people used force on her, but she went along with treatment, but she was a patient in the true sense of the word, in the sense that she was merely passive, and treatment was something that merely happened to her. And later on, I was wondering whether engaging in advanced care planning could have helped her back then. So I will talk about a study we conducted within the Salus project in Bochum on psychiatric advance directives. What are psychiatric advance directives? These are documents, or documents you can just write, that enable users of mental health services to express their treatment preferences for future mental health crises. And I will use this term, Psychiatric Advance Directive, or PADs, just as a container term. So it also includes other types of advance directives, like joint crisis plans, crisis cards, or what is called self-binding directives. So, and within our project, we conducted 2 systematic reviews on the views of service users on psychiatric advance directives. So we thought for the implementation of these advanced directives, service users are a key stakeholder, but it's not very clear what these stakeholders think about these advanced directives. So we conducted 2 reviews, one on their views and one on what they write in advanced directives. So we included content analyses of existing advanced directives and surveys in which service users were asked, if you were to complete an advanced directive, what would you write in it? And here, within this presentation, I will focus on the first review mainly, but also present some results from the second one. And so one already appeared, and the other will appear in 1 or 2 weeks. And if you don't have access to them, you can just write me a mail. So our aims was for the first review to gather and systematize the perspective of service users on psychiatric advance directives, and as a secondary aim to inform policymaking and clinical implementation of this instrument. And for the second review, it was to describe and systematize what service users write or would write in their advance directive and provide a resource for the development of guidance for facilitation of the completion process of advanced directives. So I won't bore you with all the methods, because I assume that you will be more interested in the results, but this is just to give you an impression of the sample what we have. So we cast a wide net. We got over 4,000 records in the beginning. We excluded articles based on titles and abstract in our inclusion and exclusion criteria. In the end, we accessed 134 full texts, and there for the first review, we had 53 articles included in the end. And for the second review, some of it looks the same, but we had 42 articles included at the end. And this is also just to give you impression, so the list of countries is not exhaustive, but this was kind of the countries which had the largest share in articles. And I think what is very important to see is that like almost all of the studies are included in the US and in the UK. So for the interpretation of the results, this is of course very important that we miss results from a lot of other places in the world. And we had a good mix of quantitative and qualitative studies. So what are the results of our review? So first, the preliminary, this was already known in the literature, I think. So service users have a very high interest in completing an advanced directive. So if you ask them, would you want to complete one? They say, yes, I would like to do that. And people who do it, they are also very satisfied with the advanced directive. And for example, they would recommend using the instrument to others. But then, if you look at who completes or who drafts an advanced directive, these are very little people. How come? Is of course one question. So we've looked at what service users think are the benefits of psychiatric advanced directives and what are the challenges. And this is just an overview of the general themes we found. So personal benefits, treatment-related benefits, prevention of psychiatry-related harms, prevention of harm due to lack of treatment, and social benefits. And then we had challenges, and I will go into 2 challenges only within this presentation, namely difficulties during the drafting process and problems regarding the application of a psychiatric advanced directive. And I will skip the last 2. So I'll just guide you through these topics and explain something about some items, but not all, because the data was very extensive. So the personal benefits. One great personal benefit was an increased sense of autonomy, control, and empowerment, As one service user expressed, I'll have some input in what goes on in my treatment and in my medication, and that's something I've never had before. And for the rest, we also see that it's not only about promoting autonomy, but at the same time, we also promote recovery and well-being. So these are not mutually exclusive, giving them a sense of peace of mind and of safety. Then treatment-related benefits. We found in most studies, so the N at the right column are the number of studies in which we found this result, is an improvement of the therapeutic relationship. So I have a better relation with my psychiatrist because now, finally, we have a document before us and we're kind of forced to talk with each other about my preferences. And this, of course, improved communication, as the survey user at the right said. So we had a meeting where they thought about completing or drafting an advanced directive. And in that meeting, he was, for the first time, really part of the conversation. And this could also lead to better treatment outcomes and to more adherence to treatment from the side of service users. So prevention of psychiatry-related harms. Service users thought that advanced directives could help them in preventing hospitalization. And so this is not only that they refused hospitalization in their advanced directive, but more that they thought, if I have an advanced directive, hospitalization won't be necessary. And so in a systematic review of interventions to reduce hospitalization in mental health hospitals, advanced directives indeed were the only intervention that significantly reduced the number of involuntary hospitalizations. So prevention of unwanted treatment, for example, particular types of medication or ECT, electroconvulsive therapy, was also a dominant topic there. Then it's not only psychiatry-related harms which could have been prevented by completing an advanced directive, but also certain harms due to no treatment. So people thought that if I describe conditions under which I want to be hospitalized and what kind of treatment I wish for in those circumstances, I can ensure that I receive adequate treatment. And maybe services can intervene at an earlier point of time because I expressed the expressed will to be in a hospital at that moment. And as one service user said, I don't want anyone to listen to me when I'm unwell. I want them to abide by my wishes detailed in my advance directive. And various social benefits were mentioned. So this mother, she never discussed it with a father, for example, but if you want to complete an advance directive, there's some like a concrete opportunity to talk about your wishes. So the family members also are involved and communication is improved, and substitute decision makers or proxy decision makers are maybe relieved because they know better what the person would want in the situation in which they cannot or insufficiently able to decide for themselves. So a lot of benefits we have, but the completion rates are very low. So there must be certain hurdles or challenges which prevent people from completing an advance directive. And of course, if you are a clinician or a policymaker and you want to promote advance directives in a certain population, then you want to know what the challenges are, because then you can maybe address them and ensure that they are taken away. So first, this lack of understanding of the instrument. What is it exactly in advance directive? It sounds all very complicated. I don't know exactly what it is. So it's, unfamiliarity with the instrument. We hear that a lot. And then if people get what the instrument is, then the question is, what should I write in my advance directive? And from the content review of advance directives, we saw that there are a lot of elements and aspects of care that need to be addressed. And it's not simply about just medication. So maybe you need some support in, what topics should I think about, or what do I think about these topics? It takes too much time and effort, or it's too difficult. And of course, it can also be emotionally distressing to look back on earlier hospital admissions and possibly traumatic situations. And then problems regarding application. So application is, we're now not thinking about the moment at which we draft an advance directive, but a certain person has an advance directive and now displays certain symptoms, which she described in her advance directive: sleeping less than 4 hours, engaging in certain behaviors, for example. And so the directive applies, and we should look at the treatment preferences detailed there. So one very important worry that service users have is that their advance directive won't be followed in practice and will even be just ignored or set aside. And this is expressed by this service user, which we have the quote at the right. I told my doctor I had an advance directive and showed it to him, and he just looked at me and nodded sort of, and that was it. End of the story. Another problem service users saw was that their advance directives won't be accessed in a crisis. Because if you have this document, where do you store it? Do you keep it at home, at a family member's place? Should it be in your patient file? Will the doctors look into that if you present at the crisis ward? That's all very unclear. So it's also, if you want to address this challenge, think about how can we ensure that the advance directive is accessible in a crisis. They also worried that the advance directive will have no legal force, so that, for example, clinicians can only consider it, saying, well, this is an interesting piece of information, I'll take it into account in my decision making, but now I'm the psychiatrist and I know best, and I will decide what I think is the best treatment. They also were afraid that professionals won't support or endorse the instrument, or that there's just a lack of knowledge in the whole system about this instrument. So I'll skip these two challenges, I said. Well, that gives me some time to say also something about other preferences and about the content of advanced directives. So we had some other preferences. So what are the key drivers for completing an advanced directive? So what kind of factors would motivate you to draft an advanced directive? And we found a lot of studies that people would want to have support in the creation of an advanced directive. And what they all said is that, well, it doesn't matter much. It shouldn't necessarily be one type of person that supports me. It can be a clinician, it can be a family member, it can be a friend, it can be a peer support worker, or some kind of independent advocate or moderator for the discussion. But the bottom line is that you have to be able to trust this person who supports you in completing the advanced directive. Also, a very simple intervention, next one, is just prompt people to create an advanced directive. It's like with a lot of things in life, at least in my life, if I'm not prompted to do certain things, then I won't do them. So you can just prompt people to do certain things. And then user-friendly templates or guidelines. So we have to talk about a lot of different topics if we want to complete an advanced directive. So you might want to have a template or a guideline that asks you certain questions and that prompts you to think about certain preferences you have. As the service user on the right said, I would like lots and lots of different questions to help tease out the appropriate and relevant stuff for me. What kind of advanced directive do service users want? So we found a very high preference for advanced directives that have legal force, so that clinicians are bound to the advanced directive and are legally obliged to follow it. And, also very important, they wanted to have an advanced directive that cannot be revoked at the time when service users lack mental capacity. So lack mental capacity is a technical term, but if they feel that they're insufficiently able to make decisions according to their own wishes and deeply held preferences, then they say, don't listen to me if I refuse treatment and I say I want to go home. Look in my advanced directive. Because those preferences detailed there represent my true wishes. Okay, then we kind of know what service users think about advanced directives, but now we want to know what do they write in them, or what would they write in advanced directives. And here we also found 6 domains. And for each domain we had a lot of subdomains, and I will only explicate a few of them. And first, this was, I think, an interesting finding. A lot of advanced directives had a kind of preamble in which people said, I want to be treated with dignity and respect. So 2 words that are also in the subtitle of this conference. And that kind of shows that their experience in the past has not been that they have been treated with dignity and respect. Then they tended to detail signs of crisis. So, for example, early warning signs, sleeping less than 5 hours, engaging in certain behaviors, withdrawing socially, these kinds of things. And they also indicated kind of strategies to prevent relapse. So if I show these early warning signs, what can other people do to prevent decompensation? And there was the treatment setting preferences. So they had a lot of preferences about where should I be treated in case I have a mental health crisis. So which hospital, for example, and sometimes also which ward, and do I have preferred clinicians, for example, Did I work well with a certain person in the past, and do I wish to be treated by that person again? And some people also had preferences for other types of services, so I don't want to go to hospital, but I want to go to respite house, for example. Then treatment preferences. Antipsychotic medication was only one item here. So it was important. People had requested certain medications, so that worked well for me in the past, but refused other types of medications. I experienced severe side effects from this medication. It didn't help me much, and therefore I don't want to be treated with this type of medication. And what we thought very helpful if we read advanced directives, if people also gave reasons for their preferences. And that might also motivate clinicians to act accordingly, of course. And we saw for each domain that people also tended to give reasons for their preferences in the advanced directive. But there were also preferences for example, psychotherapy, cognitive behavioral therapy, or other kinds of therapy forms, but also instructions for somatic health conditions, diabetes or whatever, and also for assistive devices like contact lenses or glasses. And of course also for other types of well-being factors, like what works well for me is that I can take a walk outside regularly, or that I see some representative of the church, and other people say, well, I prefer to be alone in my room if I experience a crisis. And then preferences regarding coercive measures. We also found that in a lot of advanced directives. So should I be very agitated on the ward, and should it be really no other alternative but to use coercion, then I want people to hold me, and I don't want to be secluded. Other people have the reverse preference. They say, if that situation occurred, I prefer to be secluded, and I don't want to be held by 5 people, because that's very intimidating for me. And in the end, social instructions. So if I experience a mental health crisis, whom should be notified? And who should not be notified? And who should visit me on the ward? And especially in certain types of unhealthy romantic relationships, who should not be allowed on the ward? But also colleagues, for example. I don't want to have my colleagues on the ward when I am in a crisis. And we also found a lot of instructions for a proxy decision maker. So if I lack mental capacity at a certain point of time, who should act as my legal representative? And this is also not possible in every jurisdiction to do so yourself, to designate a person yourself, but people tended to find that important. And overall, so we looked at the preferences detailed in advanced directives, and we looked at studies that kind of evaluated these preferences. They gave them to clinicians and then asked the clinicians, do you think you can provide the treatment as detailed in the advanced directives? And service users generally included clear and clinically relevant treatment preferences in their advanced directive. And they also stated very coherent reasons for their preferences, mostly related to past experience of hospitalization and experienced unwanted effects of medication. And the preferences were generally compatible with professional practice standards. So professionals don't need to worry too much about advanced directives, and only a very small minority of service users used or would use an advanced directive to refuse all psychiatric medication in advance. So come to my conclusion, or our conclusions, I must say. So service users strongly endorse advanced directives, and concerns that are reported in a lot of empirical studies with professionals that advanced directives may contain preferences that are unclear or incompatible with practice standards were not confirmed So professionals don't have to worry. But it's difficult to complete an advanced directive. So service users want to be supported in the creation of an advanced directive. And that was also the key driver in motivating people to complete an advanced directive. Now, if as a clinician you want to implement this intervention, you should take into account that it's a very complex intervention. So it's not only a piece of paper with some preferences about medication, but it's a process in which a lot of people are involved. During drafting, so how do you motivate people to draft one? Who do you involve in the drafting process? How are you going to moderate that discussion? Which topics are you going to discuss? And then if you have an advanced directive, how do you ensure that treatment will be provided in accordance with the advanced directive? How do you ensure that it can be accessed? Do you do online storage in an electronic file? How do you ensure data protection? There are a lot of things you need to think about. And also, for example, the evaluation of treatment afterwards. So if somebody has an advanced directive, is treated, then afterwards you should evaluate the treatment and address the question, was it compliant with your advanced directive? Yes, no. Should we update your advanced directives? Do you have changed preferences after this stay? Did you learn? Did we learn? All these kinds of questions. So you got to have a plan if you want to implement advanced directives. Thank you very much.